Hi, everyone. 12:03. We'll kick off. Thank you so much for joining us today. My name is Chelsea Cipriano. I'm the Managing Director of the Common Health Coalition. I'm joined by my colleagues, Dr. Dave Choksi, who is the chair of the coalition, and Dr. Charlene Wong, one of our close advisors who helped write this report that you're here to hear about today. I'm also joined by our Deputy Director, Rebecca Gilio, who is controlling what you're seeing right now. So thank you, Rebecca, and Velda Wang. So thank you on behalf of the Common Health Coalition. I think we're ready to kick off. The chat is open, so please feel free to drop your questions, and we'll be sure to leave plenty of time at the end to discuss them. Next slide. So this is a quick overview of what we'll be discussing today. So hello and welcome from me. That's where we are right now. Dave and Charlene will be doing an overview of the report and a deeper dive of this lovely document that we put out yesterday. And then Dave will talk about implications for respiratory virus season, as I'm sure that is front of mind for so many. And we'll jump into Q&A. Thank you. Next slide. Great. So, as I said, hello, welcome. Very quick, high level about the Common Health Coalition. In case you haven't heard of us, I'm seeing a lot of familiar faces on the Zoom right now. So I have a feeling most of you have. But if not, we are a nonpartisan, not-for-profit coalition of now pushing 300 organizations across the country, all representing different facets of the health ecosystem, public health, healthcare, and beyond. And really our one singular goal is to improve the health system. And we're going to do that by strengthening partnerships between healthcare and public health. This is what we do. We matchmake, we megaphone, we mobilize, and we do things like this where we bring the evidence from the ground to others so that they can learn from it, see themselves in it, and try to move the needle using it at their fingertips. So that's really what we've done with this report, which you'll hear from Dave. It's just a starting place. So thank you for being with us early in this journey. We're really excited you're here. So that's my bit. I will pass it over to Dave, and I think we're ready for the next slide. So thanks again for being here with us.
I'm very excited to share with you a little bit more about our report, our special report from the Common Health Coalition. I have just a few points to add by way of introduction before I have a chance to pass the baton to my esteemed colleague, Dr. Wong, who will delve really into the substance of the report that we've put together. The first point that I wanted to share is a little bit more about the provenance of why we decided to write this. And the moment in which that crystallized was in April of this year, in the wake of some of the cuts that we've seen, not just at the federal level, but particularly the ways that we were seeing disinvestment in public health affect local and state level public health activities. We saw that there was some attention being paid to the very human costs of that disinvestment, but it felt like a missing part of that dialogue was the ways in which cuts to public health also affect healthcare delivery. The ways in which when we don't fund public health, that has implications for our emergency rooms, our nurses and doctors, our hospitals and clinics, which all of us rely upon, regardless of our insurance status or our ability to pay. And so our steering committee back in April charged us to develop this report as a way to inject it into the conversation, for us to have some analysis of what this looks like and what can be done about it. The second point that I wanted to add briefly is a bit of a personal perspective. Like many of you, I'm sure, on the call today, I'm a clinician. I get to take care of patients, and there's not a single clinic session that goes by for me that I don't rely on the backbone of public health in some way. It could be when I order a send-out test for one of my patients. It could be the guidance that we rely upon, particularly for infectious diseases, but for a whole host of other diseases as well. I saw a patient a few weeks ago for whom I needed to check the New York City registry of syphilis cases to be able to know what the appropriate treatment for that patient would be. And although much of this happens in the background, it is unequivocally the case that the way that we're able to deliver clinical care rests on a foundation of public health capabilities. I know Dr. Wong is going to share a little bit more about that from her clinical vantage point as well. The third point that I wanted to make is we really try to inhabit the perspective in writing this report that this is not about being defenders of a broken status quo. We believe that modernization is needed across healthcare and public health. And really, that's why the coalition was founded, was to try to forge the collaboration and partnership that we think undergirds so much of the reimagined health system that is worthy of our patients, of our families, and our neighbors. And so what we aim to do is to call attention to the fact that there are very real harms just in the rescission of funding or staffing or operational infrastructure, but with an eye toward the opportunity that may lay ahead of us, particularly opportunity through strengthened partnership between healthcare and public health. And that segues to the final point that I just wanted to make by way of introduction, which is the importance of creativity and coalition building in this moment. And look, I know this might sound almost a bit tone deaf when we are doing everything that we can just to, keep the wheels from falling off the wagon in many ways. And there's a true, reality to that. But I think that part of our task and what we hope to accomplish by putting this report out into the world is also a bit of action on what more can be done differently. How can particularly state and regional coalitions be built to be able to backfill some of the services, that we know may be going away, but then also create new ways of organizing to benefit the health of the people that we serve. The last note that I'll just strike is that part of what I hope that creativity and coalition building will keep in mind is what we nod to in our report, which is that across the categories of cuts and their effects that we describe, the consequences will fall most heavily on underserved communities, rural areas, and people who are already facing barriers to care. So it feels only natural that we would center those people, those patients, those communities when we think about creative solutions going forward. So without further ado, I will pass the baton to the amazing Charlene Wong, who did so much to bring this report to fruition, and will share a little bit more about our analysis and thinking. Thank you.
Thank you so much, Dave. It's been a real honor to work with this whole team and so many others who really helped inform what is in this report. So, I want to just first walk through, as Dave did, a little bit of the thinking of, okay, we know that there are these cuts that are happening in a variety of ways in the health ecosystem, including to public health. And, what does that flow look like as we flow through and think about how this impacts the healthcare system? And so let me just start by saying just a bit more about the public health cuts. So, of course, maybe you think public health and you think CDC. I did work at CDC recently. And there are so many other agencies that do public health prevention work that is all about protecting health and improving lives. So SAMHSA, our mental health agency, HRSA with our federally qualified health centers, AHRQ, the FDA. And for example, CDC, which, of course, is a public health leader, the budget cuts are substantial, as Dave mentioned. So in some of the proposed budgets, we see nearly half of CDC's budget proposed to be cut. So from 9.2 billion down to 4.2 billion. And I see some friends who are on from states. And of course, this has major implications for our states because CDC, like many of those other federal agencies I mentioned, pass a lot of those dollars through directly to states and local jurisdiction. For the CDC, it happens to be around 80% of the CDC budget that gets passed through. Okay, so you look at that in the first box, right? We see these cuts to public health programs, staff, and functions. What that means is that we're seeing loss of key public health functions, both at the federal, state, local levels. I'll walk through some examples. The consequences aren't inevitable, though, right? There are opportunities for healthcare and others to come fill some of those gaps. And because the gaps are right now in some of the proposed cuts looking to be very substantial, it would be unlikely that healthcare and other partners would be able to fill all of those gaps. So what does that mean? Of course, negative impact for population health. And then what we're really here to talk more about today is what that means for our healthcare system. I'm a primary care pediatrician. Certainly, I know we're going to talk more about fall, winter respiratory season. That's a time of year. There mental health crisis. There are a lot of stresses already on our healthcare system, clinicians, healthcare system operations, our payers. And so really thinking about what these public health cuts then are also adding on to the stress that's already existing. So on the next slide, we present some of these consequences in three categories. And I'll give you an example, one from each. The first is fewer services available to patients and clinicians. And I'll give you an example of tobacco quit lines. The second is more patients arriving sicker and thus at a higher cost. And I'll give you an example from public health's important work in sexually transmitted infections like HIV. And then the third is this question of, all right, well, what are we going to do, right? Particularly from the healthcare perspective with these critical threads that are interwound, just like Dave was saying, right? Healthcare being forced to think about, okay, well, do we try to find a way to fill that gap, or what happens if we just went without because we're not able to fill that gap? And I'll give you an example from public health labs for that one. So starting with the first, which is fewer services available to patients and clinicians. I want to talk about tobacco quit lines. Maybe some of you all, hopefully many of you all on the call have heard about these quit lines. Maybe you've seen an ad for calling 1-800-QUIT-NOW. I, as a primary care physician, have referred many patients to these quit lines. They are free. They get over 10 million calls per year. And the offices at CDC, as well as at FDA, that do a lot of important work to try to prevent smoking and the many, many harmful health impacts of smoking, have been drastically downsized and in many cases actually fully eliminated. Now, I said I've referred patients to these quit lines, maybe like some of you all on this call. And frankly, until recently, I didn't really know that these lines, these phone lines, are largely funded and run by public health, which is like fine because we should be working seamlessly together. However, because now there is such a funding cut to these offices, what this looks like for quit lines, and these tend to be run at the state level, it means they're looking at a funding cliff, a big one. And that means that maybe some of them may have to eventually shut down completely. Certainly, we're already hearing some states, for example, South Dakota, that's already thinking and saying, we're going to have to cut down on the number of counseling sessions that a caller to our phone line might get. And any of you all out there who are either clinicians or maybe you're a friend who's tried to help a friend who's wanted to quit smoking, you all likely know it is often multiple counseling sessions, multiple conversations that are really needed to help someone quit smoking. Another thing that might go away because of these funding cuts, even if the quit line maybe remains, operational, but only at a sort of smaller scale, is many of the quit lines are able to offer nicotine replacement treatment. So this is the nicotine gum, maybe you've seen the patches. These types of interventions nearly double the quit rate. But again, with these funding cuts, because so much of these, many of these lines rely on over half of their funding from the federal government, these are the types of decisions that will need to be made if there's not enough resources. And I'll just add, for these fewer services, it's not just the quit lines that are really going to suffer here, but again, I'm sure many of you all have seen ads from the Tips from Former Smokers campaign. This helps direct people towards the quit line. And you want to talk about smart investment. This is the type of investment that's smart. Evaluations have shown that tip line with the quit lines have saved over $7 billion. That's a 15-to-1 return on investment against smoking, right? Which is the #1 preventable cause of death in our country. All right, so then let me move to example 2, which is more sicker, more costly patients showing up in our clinics and in our emergency rooms. So let's talk about HIV. I, as a primary care doc, am routinely screening for HIV in my practice. What I didn't know is that actually a third of new diagnoses of HIV in the US are actually made in public health funded programs. So screening that is happening in public health funded, public health run programs is playing a huge and complementary role to what it is we do in our healthcare systems for STI screening. And so what does it mean when we see proposed full elimination of HIV programs, not just at the CDC, but maybe some of you all have heard about the Ryan White program, which is an incredibly important access program for HIV supports and treatment that is run out of HRSA. There is always very critical research happening to advance screening and treatment and testing, for HIV coming out of the NIH. Well, what it means if, some of these proposed cuts go into place is that we're going to see more patients with HIV. We're going to see them showing up sicker, right, in our emergency department. So think about opportunistic infections, patients who are perhaps coming in and needing ICU care immediately, as opposed to being caught earlier on in their disease course. And a recently published study estimates that the direct healthcare costs specifically of missing these diagnoses, missing these opportunities to prevent and detect early HIV will cost on the order of over $50 billion in healthcare direct costs over a lifetime. And unfortunately, we're already under-resourced in many of these areas. So we, for example, have currently in the US, Maine experiencing one of the largest HIV outbreaks in state history in their state. Already there are too few tests. It's too hard to get treatment because there just aren't enough resources. And normally, when outbreaks like this happen, states, local jurisdictions will often call for help, and often they will call the CDC for help. In this case, because of recent staffing cuts and eliminations, the federal CDC workforce and people with expertise and who can provide technical assistance have, to this point, to our knowledge, have thus far not been able to go and do that because of the recent staffing cuts. All right, and then for the third example, and we have an image here, I wanted to talk about public health labs. So again, many of us order lab tests, and you order them, I order an Epic usually. We order them, and they look sort of the same as how we order most of our other tests, but some of these tests, sometimes they're special, more rare tests, maybe like a special parasite or a more rare threat like Ebola. Those labs that we order get sent off to a public health lab. But also some of the tests that maybe we order more commonly or more routine are also sent to public health labs. So that can include things like infant genetic screening, maybe tuberculosis drug susceptibility testing. And what you can see in this flow diagram here is how in the orange boxes, this work starts and then also ends when we're ordering labs because we're trying to figure out what a patient has, what treatment we need to prescribe. You can see in the orange boxes that starts and ends in the healthcare system. And then there's a process that includes both the clinical healthcare system as well as our public health lab partners to actually get from, hey, we want to order a test to what's the result of that test and what do we do with it. And what you can see in the arrows in this figure that is included in the report are what are the consequences when there are breakdowns or delays at the many, many steps that occur here between ordering a test and getting that answer, and of course, treating the patient, helping them get better. So this public health lab infrastructures is under threat. And so some of the things that we have in these arrows here are things that we are already hearing are happening, or certainly we are hearing from our public health lab colleagues are very much real possibilities if the funding cuts continue to be in place. So for us as clinicians, okay, so like, what do you do when you've got a patient and you're wondering, you know, I wonder if this is Ebola or not? And what happens if we can't order that test anymore at all? Or maybe we can still order the test, but one of the things that we've heard is that there are likely to be delays, right? So that might mean delays that result in a patient being in an emergency room, maybe in an ICU bed, waiting for hours longer, could be days longer, could even be weeks longer in some cases to know what that diagnosis is. Now, again, we are pointing out and really outlining some of these examples where there are anticipated consequences from when we see these public health cuts and how that will ripple and have impacts in the healthcare system. But like Dave and I both said at the top, these consequences aren't inevitable. So, you know, we mentioned in our third bucket that healthcare partners, you know, can really have an opportunity here to think about what is it that healthcare might do in the scenario, for example, with public health lab cuts. And are there ways for public health and the healthcare system to partner together? So, you know, one thing that we've heard and that we'd love to encourage and see more of is healthcare systems using this moment to reach out to their own lab team, maybe in your own hospital, reach out to your public health labs in your city, in your state, and talk about, you know, where are there already gaps? Where do we expect there might be gaps that are really going to impact our ability to care for patients, care for the communities, you know, in our state or county? And then are there ways to coordinate, just as Dave was saying, right? Are there ways to coordinate? You know, maybe the public health lab says, okay, well, we think we have enough resources, we can keep this set of parasitology labs going, but hey, health system partner, maybe would it be possible to scale up and start doing some of these other tests that if we could let those go, we could make sure to focus our resources and keep these other parasitology labs going. And I also want to call out our payer colleagues because we had several payer colleagues who also helped us think through some of these examples and some of the solution opportunities. And I think payers have an opportunity here. We heard that sometimes labs are sent to public health labs because they are labs that are not routinely or currently covered or reimbursed by our routine health insurance payers. And so again, an opportunity here for payers to work with the public health labs, to work with the healthcare systems and providers to say, okay, you know, what are the opportunities so that we can make sure that patients, that providers, that our communities have access to these critical lab services. So those are three brief examples that we chose because, you know, we hope that you found them as tangible and data supported and compelling, you know, as we do, including that, you know, there are real consequences that are potentially anticipated here and opportunities to really come together and figure out some solutions in the short, medium, and hopefully longer term so that, again, it's all about protecting health and improving lives altogether. Let me turn it back over to Dave to do a deeper dive on respiratory virus season.
Thank you so much, Charlene. That was a really lucid description of the three categories that we go through in our report. And in addition to the shout out that you just did for some of our payer colleagues, I also wanted to just underscore how much this report stands on the shoulders of so many colleagues, you know, who have done research in this vein over years, if not longer. And there are a couple of folks I'll just call out because I happen to see them on my Zoom screen who really made vital contributions to specific elements of the report, including Dr. Dora Ann Mills from Maine, Dr. David Holtgrave, and Dr. Nadine Gracia from Trust for America's Health, which is also a member of the steering committee of the Common Health Coalition. So I'm sure I'm missing some folks, but I at least want to do a tip of the hat for so much of the vital underpinnings that we were able to try to synthesize through this report, as Charlene described. So for a few more minutes, I thought I would um, take the baton to talk about implications for respiratory virus season. Um, Respiratory virus season, as I know many of you have experience with, is an extraordinary challenge every single year. In fact, you know, the memory that's coming to mind for me is one of the first patients that I ever took care of as a medical student. This was almost 20 years ago now, but I remember it like it was yesterday because it was a baby, an infant with RSV, which has been all too common for decades in the United States and around the world. And you never forget the first time you see a case like that because um, you see the baby's uh, skin, being sucked in between their ribs in each breath, their nostrils flaring, soft grunts with each exhalation, and rapid, shallow breathing, sometimes a bluish tinge on their fingertips or their lips from cyanosis, and their belly, pushing out with each breath. It is a struggle that you often feel helpless about because so much of what we do for RSV with infants is supportive care. But that has changed in recent years because we now have much better ways to prevent the suffering that is associated with RSV for kids as well as for older adults. But specifically, for infants, we now have the protection afforded by maternal vaccination as well as a new monoclonal antibody, nirsevimab. Each of these things that are associated with respiratory virus season, RSV, influenza, COVID-19, is an intricate interplay of making sure that all of the various pieces of our health system, from pharmaceutical manufacturers to payers to providers, not just physicians, but of course nurses and pharmacists as well, along with public health agencies, all act in concert to try to prevent the suffering that that is wrought by these devastating illnesses. And so we thought, as part of this report, we would shine a spotlight on some specific implications of public health cuts and also other challenges, headwinds to public health. Of course, we're having this briefing at the same time that the newly constituted ACIP Advisory Committee on Immunization Practices is happening, and there is, ongoing confusion with respect to some of the guidance related to respiratory virus vaccines. And so, the way that this applies in terms of the framework that we had developed through this report to respiratory virus season is what's laid out on this diagram. You can see on the left-hand side the way in which cuts to vaccination, education, outreach, and operational infrastructure leads to tangible changes, like some people who are just not able to access vaccination, or challenges with respect to understanding which populations or subpopulations are eligible for the various prophylactic interventions. There is, just given the pace at which these things happen, and as Charlene alluded to in her comments, limited healthcare capacity to fill the gaps in immunization infrastructure. Although, as I'll talk about, we should not accept that as a static quantity. This is something where there is a mobilization that can help fill at least some of the gaps. This leads to overall, potentially declining immunization rates, particularly among the most vulnerable populations. I have been following some of the evidence on this, which indicates that just based on the numbers needed to treat for the respiratory virus vaccines, even a single percentage point increase or decrease in vaccination rates for any of the three viruses that we're talking about, flu, COVID-19, or RSV, it results in about 1,000 or more hospitalizations across the United States. So you can draw the line between between access to vaccination and what that looks like in our emergency rooms and hospitals. Overall, this leads to additional strain on the healthcare system. So this is an area where the Common Health Coalition is thinking deeply, along with a number of other partners, about how we can be best prepared ahead of this upcoming respiratory virus season, not just for the challenges that exist in any given year, but for the particular challenges that may exist in this year. I wanted to draw attention to one specific element, again, with a nod toward solutions and not just admiring the problem. And that's that a number of the founding members of the Common Health Coalition released statements just yesterday affirming their commitments to ensuring access to vaccination for influenza, COVID-19, and RSV. Specifically, AHIP and ACHP, which are two of the leading organizations of health plans, released statements. And then the AMA, along with 79 other medical societies, released a statement in parallel as well. If you use this QR code, you'll see our own message about this, essentially applauding the leadership of those organizations and calling attention to what each of us might do to prepare ahead of respiratory virus season. This is very much a work in progress that we have going on, and we wanted to surface it in part today to invite your feedback about what more could and should be done. We think about this, as I said, every year for the coalition. We have to think about Christmas in July, as it were, because it takes that time to prepare for us to be able to ensure that there's access and that people are able to afford the protection that should be something that everyone is able to access rather than something that is an exception. So with that, I know we want to turn it to Q&A, and so I think I'm passing it back to Chelsea to help with that.
Thanks so much, Dave, and thanks, Charlene. So we do have some questions that were submitted ahead of time, but just want to remind folks, please drop any questions into the chat and we'll be happy to answer those in real time. Also in the chat, you'll find a link to the report itself, just a reminder of that, and then the statements that Dave just mentioned from AHIP, ACHP, and AMA that came out yesterday about vaccination access for respiratory season. Great. So turning to questions, Dave, I will pass this one to you to kick it off, and then feel free to pass to Charlene. One thing that we're getting from folks is, can you help us understand how these cuts to the public health infrastructure may differ to previous funding reductions or infrastructure changes that have happened in the past that necessitates the calling out in a report like this?
Yeah, this is a great question. And look, in some ways, I think we should think about them similarly. And that's something that should give us some succor, right? We have encountered downturns before and have had to respond to them and rally, to be able to continue to protect people. At the same time, there are some very real differences. The scale of the cuts that we have seen thus far are categorically different. Again, not just at the federal level, but in terms of the local and state funding that is reverberating on the ground with entire programs being cut rather than sort of incremental changes with respect to funding streams. So the scale is one aspect to keep in mind. And then the other one is to just point out that there are compounding effects that we called attention to in the report, because, of course, we're talking about the ways in which healthcare and public health can work together. But healthcare funding is also under deliberation in Congress right now, and there are steep cuts being contemplated to healthcare through Medicaid and the Affordable Care Act and potentially other related programs. And so we have to have a wide-angle lens to take all of those things together to realize this is truly a different moment for us to rise to. That's what comes to mind for me, but Charlene, I'm sure you have other thoughts as well.
Yeah, no, I think that's right, Dave. And I think the, other thing that certainly I think folks on all sides of the health ecosystem are feeling is that there's just so much change that's happening so quickly that's happening and then sometimes comes reversed. And, in public health as well as healthcare, right? The ability to plan, right? And be prepared for things like respiratory virus season, right? Is like a thing that we know that comes every year. It's just made exponentially harder with the cuts that have already happened and so much uncertainty about what might come next. And so, again, as we call it in the report, we hope that some of you all who are on the call and who are reading, who are in positions of influence and leadership in health systems, for example, like please use some of these examples to think about like, are there things that you can do now to maybe be starting to get prepared or at least do a little bit of scenario planning? Because again, as Dave said at the very top, the people who are going to really feel the impacts of this in the most real way are going to be the people, the patients, the communities that we're all trying to serve.
Thank you both. I'm going to pull a thread a little bit on something that you said, Dave, and maybe pass to you first, Charlene, actually, about the role that some creative thinking here on solutions plays. And so, have you seen states or localities or health systems working on solutions to try to address some of these big funding gaps in partnership with each other, particularly on Medicaid? Is that something that we've seen on the ground happening in real time?
Yeah, I'll start and Chelsea, I know you have some examples as well to perhaps share here, but let me start with Medicaid because so I have heard from several colleagues who have worked in Medicaid at both the federal and the state level say Medicaid is also a public health program, right? So much of what Medicaid does is about disease prevention, health promotion, protecting health and improving lives. And so, I just want to say, like, to start with that when we're talking about finding solutions now as these cuts are put into place or coming potentially into place, there's also such precedent, right, where things that started in public health end up becoming integrated and are just our very routine part of healthcare. And importantly, the dollars and the way that things happen, or the operations as well as the funding, actually shifts over into the healthcare system. So, as an example, our diabetes prevention program, right? This is something that very much started in public health and is now very part and parcel of what we do in healthcare. Also concerned about threats to some of the funding there. But let me give you an example. I've talked to some Medicaid colleagues in the vein of vaccinations. And one of the things that we also reference in the report that is a potential implication of these cuts is the immunization data, right? So how I, as a primary care pediatrician, know, okay, Johnny's sitting in front of me, what immunizations should I be, recommending today and ordering today? Well, friends, it takes dollars, right, and resources to keep those systems up to date. I want to have great confidence, right, that whatever my EHR is telling me Johnny needs is in fact actually what Johnny needs. We are already seeing in some states, because of even the cuts that have already been put into place, those sorts of systems starting to deteriorate. So, for example, Maryland had a wonderful system so that anyone, you don't have to go into your EHR, you could just go onto a website and you could see, okay, what vaccines have I had? What am I due for? That actually already got pulled down. But let me get to a solution. And Medicaid, there's a couple states that have done some creative things in Medicaid to help with this. So there are states, for example, that have worked with their Medicaid managed care organizations, those plans, to say, hey, guys, you guys are using data from these immunization systems to track on things like performance measures. And the same way that you pay for other data that you use, it would be fair, right? It would be appropriate to also kick in dollars to use these data, right? That public health is funding. And so they've been able to do that. And then as a cherry on top, of course, then you get some federal match dollars as well to support that very critical infrastructure. And I hope we can see more solutions like that, because what we really don't want, and having worked globally, I'm sure Dave has had this experience as well, like, needing people to bring in their actual vaccine cards, right? Or like piecing together records, trying to figure out, okay, what does Johnny actually need today? Because those systems actually fall into such disrepair and being out of date that we can't actually use them. That would be horrible on all sides.
Thank you, Charlene. Dave, anything else to add on the solutions creative thinking front?
No, I think that was really well articulated by Charlene. I wanted to invite you, Chelsea. I know you've done some deep thinking here. If you have an example or two that comes to mind, please do share it as well.
Yeah, I think we've seen some really great work already, right? Not even in the context of these cuts, but just over time in the creative use um, of Medicaid partnership in with public health, right? We've seen it in Oregon with their work on access to air conditioners and help with utilities and helping try to get into this prevention space through Medicaid, through shared responsibility. Washington State does some really cool things with community health workers, and that's another diatribe that I won't go down, but we should center community health workers and their role in how they are already always kind of filling those gaps in services and information exchange. And so, how are we thinking about better and more sustainably integrating community health workers into our systems? And there are many, many examples on our website and beyond of amazing work happening in that space as well. I think there's a lot happening across the country, and many on this call probably are part of those conversations with states about data exchange, right? And how do states work together in creative ways with healthcare to say, we have this data, you have that data, and how are we securely sharing it between partners to fill gaps, particularly at state and regional levels. We're hearing that it's happening. And one thing I'll say, we're eager to amplify it. So if you're listening to this, you're like, we're doing this work. We're doing this cool work to not just fill gaps, but it's how we've been doing business as usual for years with our healthcare partners or public health partners. We want to know about it and we want to amplify it for you because this is what folks need to be thinking about right now is how are we embracing these partnerships to help meet the moment. So thanks, Dave. I think there's a question, Dave, that I will pass to you in from the chat from Julie in the chat. So, what is being done with state and regional coalitions to stop the cuts from happening? So a bit different, but a fair question nonetheless.
Yeah, great question. And before I answer it, I do want to also just call attention to a comment from Danielle Green just below that question in the chat to tack it on to the thread from earlier about, how should we be thinking about this time differently? And I do think it's such an important, question for us to make sure that we have a sophisticated mental model of, because the solutions flow from the right diagnosis. And so Danielle's, comment, which I'll just read out here. The other thing that makes this time different is the simultaneous deep cuts to funding and programs in the broader system, education, food, housing, et cetera, which not only will make individuals more vulnerable, but affect the ability of states and local jurisdictions to backstop the funding or fill in gaps in health areas. Another way of thinking about this is, for all of the ferment around health-related social needs and social determinants of health, let us not forget that that works in reverse too, unfortunately, with respect to the ways in which, those adverse health effects redound when there are threats to things like our housing and food and education systems. So I thought that was a really important point. And then over to this question about, what's being done with state and regional coalitions to stop the cuts from happening. This is a really important question, and I'm glad that it's framed around state and regional coalitions, because I think that's where, a lot of the most productive activity can happen. There are really important funding streams, that flow at the state level in particular, that need to be preserved in this moment, and can be and are even more vital given what we're seeing at the federal level. I also do want to call attention to the fact that, as we've talked about, the potential cuts to Medicaid and the Affordable Care Act, there are a number of groups organizing around that. I see Rishi Manchanda on the call as well, and I know that he and Families USA and others are organizing to ensure that there are broad-based coalitions, to raise voices around what the tangible impacts of cuts might be. I think the most important thing is to lend our voices. If you're a public health practitioner or a clinician, It matters so much for policymakers to hear about what this means very tangibly for the people that you're serving. And I guess the corollary to that is if you're not finding an organization, that is leading the charge in your jurisdiction, then that's an opportunity. But you can tap into some of these national networks that have formed in order to get the right information and tactics to be able to help draw attention. So those are my thoughts.
One question that has popped up in the chat I see down below from Michelle is in reading these examples in response to what we've shared of our examples from the coalition website in terms of these exemplars of partnership across the country. They take an investment of funding. Are you able to point to examples that reduced costs? So, Michelle, if you don't mind, I'm also going to take a bit of that question as well and ask Dave for you to start and pass to Charlene. Can you, speak to that question about investments and partnerships reducing costs, but also the opportunities outside of just relying on philanthropy to try to fill these gaps and how folks should be thinking about that?
Yeah, and look, we have to have a very reality-based lens on this conversation because there are no easy answers here with respect to, trying to backfill the funding cuts. With that said, I do think that the mindset that we should inhabit is one of creativity for things that we've talked about for years, when it comes to figuring out how to ensure that some of the downstream beneficiaries of public health interventions are investors in those interventions in the first place. So we're talking about things like, if there are emergency department visits or hospitalizations that are avoided as a result of a public health intervention, then how can we forge partnerships with healthcare systems and health plans to invest in those things in the first place? There are, possibilities for more innovative financial mechanisms. One in that vein that we have thought a bit about is the notion of public health bonds. To be able to solve some of the financial challenges in organizing this, things like the wrong pocket problem, or the fact that often we're dealing with longer timeframes when it comes to seeing the results of investment. There's one other thing that I wanted to add before passing it to Charlene, which is that I do think for people who are more inhabiting the public health side of this equation, it's very important for us to bring as much rigor as we do to our epidemiologic investigations to thinking about return on an investment in a sophisticated way. First, to ensure that ROI is an analysis that we have some capacity to do in the first place, and then that we are as sophisticated as possible in thinking about the specific sectors, to whom we ought to be demonstrating ROI for. Sometimes we only take the societal perspective, which of course is important. That's why we're doing the work that we do, but also bringing a lens of, healthcare systems and payers or health plans to those calculations as well.
Thanks. Dave, I'll just add two quick things to what you said, maybe to also speak to the upfront investment part. I just want to give two examples of ways, some of the bigger examples that are given, yes, certainly requires investment, people, resources, resources to bring in, tools and develop tools, things like that. But for example, when I've worked in public health and the healthcare side at both the federal and the state level, sometimes they're smaller things. So let me give you an example. When budgets are strained, something that often goes first is the communication budget. And so some of the work that we've done where we've linked across public health and healthcare is to say, okay, none of us have as many communications resources as we'd like. One way that we can still maximize the reach of important toolkits, key messages, key stories is let's share to each other's networks and via each other's communication channels, right? These tools, these things, and even bring together people in, it's as simple as a webinar, right? Where people have a chance to hear and maybe even smaller groups to actually have discussion between themselves. So again, that is a tiny, tiny bit of investment, but not something where you maybe need to go and seek external funding to create that type of partnership. The second type is just to, and we did a lot of this, which is public health and healthcare are already investing in things. People have got their strategic plans, their priorities they're working on. Looking for those opportunities, I think, as Dave has referenced a couple of times, where you're working on the same thing. So I'll give an example that is a common area at all levels of public health and healthcare is maternal health. Right. There are a lot of folks who are working to address the maternal health crisis, the disparities, different pieces of that. And so, for example, at CDC, we were working very closely both with, for example, our federally qualified health centers. We were also working very closely directly with private payers. And I'll just say, sometimes those private payers, they said, oh gosh, you guys have a lot of great data and tools. Honestly, we hadn't been paying attention to that, right? We were doing our own thing over here with a contractor, but you're showing us the data. So we really need to be focused, for example, on hypertension in pregnancy, because you're showing us that's actually the number one reason that Black women in our country are dying around pregnancy. And actually our programs we've put in place now are not actually really doing anything about that. We want to pivot, right? And so it's pivoting resources they've already invested, but pivoting them to use them in a more effective way. So just two examples there. And then I just have to double tap. I saw that Dora Ann put in a comment, another example of something that started in public health and that has been, again, a solution fully integrated into healthcare in so many ways, which is are the vaccines for children program, such a great historical example. And also, you know, a harbinger, I would say, for if we don't have some of these programs, like, you know, for the MMR vaccine that was born out of the last nationwide measles outbreak, as she said, in the late 80s and early 90s, right? Like, we don't want history to repeat itself because we actually do have this incredible shared joint infrastructure.
Thank you, Charlene. And yes, thank you, Dora, for that comment. Okay, I think we're nearing in on the end, but I do want to ask a question about communicating about all of this. To your point, Charlene, communications often is an afterthought. This is really wonky, right? These are like, it feels like a really wonky topic with really real world and real life consequences if we don't get it right and how we're talking about it. And so I'd love to hear from both of you. How do you recommend that folks who want to talk about these issues do so to capture an action-oriented frame versus one that may just be seen as a little too, you know, wonky or drowning in data or, you know, or that kind of language to understand. So Dave, I'll start with you. How would you approach this?
Yeah, it's a great question. And the way that we communicate right now, and you know, not to be hyperbolic about it, but will translate into our success in the future. And so making sure that we are as thoughtful as possible about effective communication really matters for the ultimate impact of the efforts that we're talking about. I'll just point to a couple of you know, sort of common pitfalls that I think we have to guard against. One is believing that the facts or the data are enough. You know, too often we confuse a battle over facts for what is actually a battle over trust. And in order to, you know, win that battle for trust, we have to think about not just the messages, but who our messengers are, as well as how to tell stories that feel like they are human and moving in order to persuade people who don't already see the world, you know, in the same way that we do. The other thing, and we did, you know, attempt to do this, although we welcome any feedback on the report in this vein, is to make sure that we're not only calling out the problems. You know, there has to be at least a direction toward solutions so that it can get the conversation started for people to be able to say, well, look, you know, that does work in the context that I'm operating in, or it doesn't. But too often we stay focused on charting the contours of the problem and not moving toward solutions. I guess the last thing that I'll say, because this might be my last piece in this event, is is just to invite, your comments on where we should take this work going forward. We very much saw this as a first salvo, for things that we care deeply about, but also an invitation to think about what are the quantitative analyses, the modeling that may be particularly salient, for example, for respiratory virus season. But also to your question, Chelsea, the aspects of communication that people are finding most missing or need, material to help with.
Go ahead, Charlene.
Yeah,
Anything to
agree with
add?
everything Dave said, and just briefly to add, I think one, again, we worked with many of you all on the call and many other experts to come up with these three consequence buckets, we'll call them, as I called them earlier, because, our public health system does a lot, our healthcare system does a lot. And even, we hope that one way you can communicate about some of these changes and some of the solutions is by using these buckets, right? So thinking about fewer services for our patients and our healthcare teams, more sicker and costlier patients because of these cuts. And then third, healthcare and other partners thinking about, okay, what are those solutions, right? Or how can we backfill? What are the other partnerships and get creative, as Dave said, right? So I would say that, and then I will just plus 10 on Dave's comment about the stories. And I think certainly Dave and I gave a lot of stories from our vantage points as being both primary care physicians. Everyone can bring a story from their own perspective. I'm also a mom, I'm a wife, I'm a neighbor, right? And so, the types of implications that will and consequences we'll see from these cuts will be felt in different ways from those different vantage points. So just, really use your voice, use your stories, because they can be so compelling and you be the difference maker.
Great way to end. We are at time, y'all. Thank you so much for joining us. Again, we want to hear from you. So please send us an email, info@commonhealthcoalition.org. We want to hear from you about this report and what else we can do to help you navigate all this. So thank you so much and have a great afternoon.